This is a little unfair because I can't see anybody's faces. So it's sort of like I'm talking to, to an empty room. But please do feel free to ask questions in the chat as they come up. Don't feel like you have to wait for the end. I am going to start with a cartoon so that we can sort of orient ourselves to what we're going to be doing here today, because I can't teach you everything that you need to know about how to think about sample size for a given clinical trial in an hour. But hopefully what we can do in this hour is to sort of give you a big picture of the sorts of concepts you need to consider and an idea as to how the conversation should go so that it does not go like what we're going to see in the video.
I have a study, and I need to know how many patients I need. I think I only need 3 patients.
Okay, what kind of study is it?
I'm doing a lab study. Can I just use 3 patients?
That depends. What are you trying to show?
We always use 3 patients.
Okay, what are you trying to show?
I'm trying to show that drug A and drug B are better than only drug A.
How are you measuring if it is better?
We are looking at apoptosis. Can we just use 3 patients?
What kind of measure of apoptosis? Do you know how variable that measure is?
We always use 3 patients. That is what we have published before.
3 patients per group or in total?
Yes.
Okay, let's try something different. What type of measure are you using? And is this an in vitro study? An in vivo mouse study?
It is an in vitro study of patient samples, and we are looking at measures of apoptosis after treatment with drug A and drug B versus drug A and control, and drug B alone.
Oh, how many groups are you analyzing altogether then?
My grant is due tomorrow. I just need to know if I can just use 3 patients per group.
Okay, well, you probably should have come to me earlier for help with this.
All I need you to do is tell me that 3 patients are okay.
So, it is not that easy. Your marker for apoptosis may have a large amount of variability associated with it that could make it difficult to ascertain differences based only on 3 patients per group. It also depends on what kind of outcomes you are looking at. Are you looking at normalized changes in expression levels from baseline? 3 patients may not be sufficient to detect differences in these expression levels between the different treatment groups.
I do not understand.
I'm saying that you may need more than 3 patients per group, but that I need more information to determine that.
The serine protease granzyme B is made in cytotoxic lymphocytes, where it is inactive due to the low pH of the storage granules. It is measured immediately upon delivery into target cell cytoplasms, where the pH is neutral. This is followed by cleavage of procaspase 3 by granzyme B in the target cell cytoplasm and the subsequent induction of apoptosis. All proteolytic events can be quantitated at the live single-cell level by flow cytometry and imaged by confocal microscopy.
I understand very little of what you just said. Maybe we should talk more about this.
I just need to know if 3 patients are enough. My grant is due tomorrow.
We will need to meet to better understand this before we can determine the appropriate sample size.
I can put you on my grant for 0.5% FTE. You can design and analyze the data later.
Do you really think that is enough to do the work?
Well, it may be less if it is awarded and the budget is cut.
Please go away.
Now, none of your biostatistical collaborators, with this course at least, will ever tell you to go away, I'm sure. But I would be willing to bet money that we have all had an experience like that one. So, oh goodness. Okay, so now we will, now that we've oriented ourselves to what we're hoping not to do, we can get started with the actual presentation. Let's see here. Do you all see my slides? I hope so. Okay. So we'll start with a couple of disclosures. I don't have anything that is relevant to this talk, but I do receive some consultant fees for various things. I've reworked the talk so that any examples, although they are sort of real life examples, they don't actually reference any unlabeled use of anything. So we don't have to worry about that. And I've given this talk for a really long time. I did rework it a little bit this year to try and make it a little more up to date. The disclaimer maybe is still a little bit old. My typical disclaimer is that this talk is really geared towards a superiority trial, the situation where you have two arms, you're randomizing patients to those two arms, and the intention is to show that one treatment is better than the other with regard to some outcome. And specifically, we're thinking about a situation where the deliverable at the end of the trial is the p-value from a hypothesis test. That's where we're going to start today. I am going to change things around a little bit. We're going to spend a little bit of time talking about other scenarios because there are many other trial designs where the objective might be something other than a demonstration of superiority. You might be interested in evaluating futility, and we'll talk about what that means, or non-inferiority. There are situations in which the end result that you're going for might be something that's not a hypothesis test. It could be an estimate of precision. It could be the selection of a particular agent or a particular dose. And in those cases, certain factors that we talk about here may not be as relevant. They may be more relevant. And the process in determining the sample size and how we think about it may be slightly different. So just keep that in mind. Oh, sorry, I will try to keep chat. Thank you. So why do we worry about power and sample size? From a purely theoretical perspective, we worry about power and sample size because it provides us some level of assurance that when we get to the end of the trial, we have a reasonable probability of a conclusive finding, right? We don't want to spend a lot of effort, spend a lot of resources to get to the end of a study where we're not really sure what the answer is. This allows us to really focus our resources so that we can determine the sample size that's necessary and do a trial just that big, not bigger, not smaller. And of course, there are some ethical considerations. A study that's too large means that we're exposing subjects when we didn't have to, and that is costing more money than we could have spent. And a study that's too small implies the potential for misleading conclusions. And again, then if it's too small and we're not going to be able to answer our question, then the experimentation is really unnecessary. From a practical standpoint, we worry about power and sample size so that we feel confident that we're answering the question of interest as well as we can, right? So this is an example from the relatively recent literature, 2015. This is the therapeutic hypothermia after out-of-hospital cardiac arrest in children study. And so this trial was looking at children with cardiac arrest who required chest compressions for at least 2 minutes and remained dependent on mechanical ventilation after the return of circulation. And they were randomizing patients then to targeted temperature management for 120 hours. So therapeutic hypothermia versus therapeutic normothermia. And the primary outcome was survival with a good neurobehavioral outcome at 12 months. The trial sample size was 276 children, and it was powered to detect an absolute effect size of 15 to 20%. So all of this comes from the New England Journal article, the references at the bottom of the slide. So as I mentioned, the primary outcome was survival with a good neurobehavioral outcome, and 20% of the hypothermia subjects achieved this outcome versus 12% of the normothermia outcome. So that's a 8% absolute improvement in the primary outcome. But the p-value at the end of the study was 0.14, right? So the conclusion in the manuscript is that in these children, therapeutic hypothermia did not confer a significant benefit. That's what we have to conclude based on this result. The issue is, again, this notion that the trial was sized to detect a 15 to 20% difference. And so the limitation section of the manuscript actually addresses this. It says, on the basis of the observed confidence limits for treatment differences, a potentially important clinical benefit cannot be ruled out, despite the lack of a significant difference in the primary outcome measure. A larger trial might have detected or rejected a smaller intervention effect. Okay, so again, this is the scenario we're trying to avoid. When we get to the end of the day, we're hoping that we have a study that has sufficient power to detect whatever that minimum clinically important difference is. In this case, the detectable difference was 15 to 20%. But if you were the parent of one of these children and you had the possibility of an 8% increased chance, right, that would probably be clinically meaningful. So we want to avoid this situation. There are lots of factors in determining sample size, and we're going to talk about all of these today to varying degrees. We're going to start by talking about some of the statistical concepts that I hope that you all are familiar with, but we'll talk about them just in case, as they are relevant to how we talk about sample size. We're going to talk about that minimum scientifically or clinically important difference. We're going to talk about the variability in the response, and we're going to talk about the experimental design and how those things play a role. So first things first, before you can have this conversation with your biostatistical colleague about the sample size, you have to have a very clear statement of the research question. And at the beginning of this course, I don't know if they're still doing it that way, but we often talk about these sort of elevator pitches where you have 3 to 5 minutes, right, to explain what your question is. And that's fine for conversations in the elevator. But when you sit down with your biostatistical colleague, you want to be able to state your research question in the form of testable hypotheses. And that means we need real specifics. So we need to know what the population is that you're studying, what the response variable is, what you're comparing it to. So are you comparing to treatments? Are you comparing to time points? Are you comparing pre and a post? And at what time point are you looking? Are you following these patients for a year? Are you following them for 30 days? Are you analyzing them or collecting assessments on them repeatedly over that year? All of this information can play into how we think about the sample size. So from a statistical standpoint, we have 2 hypotheses that we consider, and these are reflective of the 2 states of nature. So I often think that it's easier to start by thinking about the alternative hypothesis, because everybody knows when they're developing that elevator pitch, what it is that they want to show, right? So at the end of the day, you've written the abstract. What is that final statement that describes what you found in your study? So the alternative hypothesis is that statement that you want to be able to conclude. So in many cases, it's the intervention affects the outcome, whatever that outcome is. The null hypothesis is effectively the opposite of that, the statement you want to contradict with the data. So again, in many cases, it's the hypothesis that nothing unusual is going on. The intervention doesn't have any impact on outcome. Okay. So we conceptualize nature as belonging to one of these states. Either the null hypothesis is true or the alternative hypothesis is true. They can't both be true. And then you collect data from the real world. And if the data clearly contradict the null hypothesis, then you trust the data and conclude that the alternative must be true. But if random noise or measurement error or chance can account for what you've observed, then there's no reason to go with the more complicated alternative hypothesis, right? So this is sort of the underpinning of the basic statistical method for evaluating scientific experiments. Because we have 2 possible truths, right? The null hypothesis is either true or it's false. And I hope you all know that there are only two possible decisions that we can make at the end of a trial, right? We're rejecting the null hypothesis and concluding then that the alternative is true, or you're failing to reject the null hypothesis. So if the null hypothesis is true, that means your intervention does not work. And so we hope that in that situation, we would fail to reject the null hypothesis, right? If the null hypothesis is true and you reject the null hypothesis and conclude that the intervention does work, that's an error we'd like to avoid. We refer to that as the type 1 error. And we control that error by specifying at the beginning of the study the level of significance, okay? Our willingness to make that mistake. Conversely, if the null hypothesis is false, which means that our intervention does work, and we reject the null hypothesis, we conclude that the intervention works, that's a correct decision, okay? And we want the likelihood of our being in this scenario to be high. If the null hypothesis is false and we fail to reject the null hypothesis, again, that's an error we'd like to avoid. And so we restrict the likelihood that we make this type 2 error by either specifying, again, our willingness to make this error, or in many cases, we think about it by specifying a high power, right? So these two sum up to the only possibilities if the alternative is false. Okay, so the level of significance, we'll start there. And I think most people are familiar with this concept. So the interpretation of the level of significance is that even when the null hypothesis is true, we're going to make a mistake and conclude the alternative alpha times 100% of the time, okay? So we pre-specify this in the trial design stage. That's very important because it affects our sample size. What I think people often don't realize is that although alpha is often set at 0.05, 0.05 is not a magical number, and it should actually be based on the willingness of the investigator to accept a false positive. Okay. There are some statistical considerations, and we'll talk about this, but I'll show you here. So this is a curve that represents what we might see for the distribution of our test statistic, let's say, under the null hypothesis. So if there's no difference when we do multiple trials and we evaluate what the difference is between our two samples, we're going to get a distribution for that test statistic, and it's going to be centered around 0, and it's going to have some, smaller probabilities out in the tails. It's going to look like the normal curve that you see here. What I'm showing you would be a one-sided hypothesis. So if we are willing to accept a 10% error rate, then what we're saying is that anything in this shaded region out here would be rare enough under the null for us to say, if I see something out here in the shaded region, that's so rare, I don't believe the null is true anymore. I'm going to go with my alternative. Okay. As that type 1 error decreases, the shaded region gets smaller, right? So now we've moved to a one-sided alpha 0.05. Again, 0.1, 0.05, the shaded region gets smaller. 0.01, the shaded region gets smaller still. So what you're saying is you need to be more sure that what you've observed is not consistent with the distribution under the null hypothesis. Now, I've taken out the graphs that show you how this plays out in terms of the power. But what I hope you can see is that as you make it easier to make a type 1 error, you will also make it easier to conclude a difference, right? So again, we'll see that in just a second. The power is the other design feature that we specify from a statistical standpoint. So the power is the probability that we reject the null when in fact it's false. And the interpretation is very specific, and people often don't think about how we specify this. The interpretation is very specific to a given value under the alternative. So you can't say, how many subjects do I need, and expect someone to give you an answer. They're gonna say, to detect what difference? How big a difference do you need to detect? Because under different effect sizes, you're going to need a different sample size to maintain the same power. So the interpretation is that for a given value under the alternative hypothesis, we're going to reject the null in favor of the alternative 1 minus beta times 100% of the time. And this, of course, is related to the sample size. So what we're going to do from now on is we're going to sort of think through some examples and how these things affect what we're talking about when we're having this conversation. So I'm going to start with a continuous outcome. This is a phase 2 clinical trial in subjects with acute ICH. And because we're looking at a continuous outcome, I'm going to say that the intervention, whatever it is intended to impact health-related quality of life. And we're going to measure that using the NeuroQual. Okay, so I'm going to start by telling you that phase 2s, I think, are perhaps the more difficult trials to design. And I'm going to say that specifically because in my time with the clinical trials course, that's often the stage that many of the trainees are in. But it's very easy for a phase 2 clinical trial to look like an underpowered phase 3 clinical trial because of sample size limitations. Okay, so let's look at and think about how that happens. So I talked about the level of significance and its impact on the power. So what I'm showing you here is the relationship between sample size on the x-axis and power on the y-axis when we're conducting a 2-sample t-test for the mean difference. Okay, and so for all of these 3 curves, I've held everything else constant. Okay, the only thing I'm changing is the alpha level, the level of significance. So if I have 100 subjects and I want to test my groups with an alpha of 0.1, I have 80% power with those 100 subjects. If I want to test it at 0.05, now I'm down to 70% power. And if I want to test it at 0.01, I'm down here less than 50%. Okay, so the alpha level, although increasing the alpha level will give you better power for a given sample size, it also makes you more likely to make that type 1 error. So there is this trade-off. Again, if you want to control it at 0.05, that's fine. But 0.05 is not a magical number. There may be some instances where 0.1 is okay. Consider maybe an intervention where you are randomizing patients to exercise versus not. Okay, whatever that outcome is, right? It's hard to think that exercise would be bad. Okay, so maybe a 0.1 is okay, because even if you made a mistake on the particular outcome that you picked, there might not be safety concerns or any real consequences to telling people to get some extra exercise, even if it doesn't really work on the outcome that you picked. On the other hand, if you were doing a surgical intervention versus medical management, let's say, in order to subject people to the additional risk associated with the surgery, you might not be willing to take a 5% type 1 error rate. You might say, no, I need it to be 1% because I want to be really sure that what I've observed is not consistent with chance in order to subject these patients to the surgery. So again, 0.05 is not a magical number. We sort of operate as if it is, but there can be justification for other levels. Okay, the minimum scientifically important difference is, again, as I mentioned, one of the things that your statistical collaborator will ask you to specify when you're having this conversation. And it can be very hard to identify what it is. Specialists within a given area may not agree on what it is. But when we think about it, we think about the smallest difference, which would mandate a change in scientific practice. Okay. Now, this is important because sort of the rule of thumb that people understand is that the larger the difference you want to detect, the smaller the sample size. Often what happens is that people start out by saying, well, even a 2% improvement in mortality would be clinically meaningful. And then we look at the sample size that's associated with that 2% improvement, and it's not feasible. And so there can be some back and forth. There is sometimes some justification in terms of, weighing what the side effects might be or what the cost is associated with an intervention and how difficult it is to administer or adhere to and things like that. But this is generally a clinically driven or a scientifically driven value. And again, it does have an impact, as I'm sure you are all aware. So in this case, what I've done is I've held everything fixed except the mean difference. So the variance is the same, the type 1 error is the same. And you can see here, I'm going to go, let's do 200 subjects. So for a sample size of 200 subjects, if I want to detect a difference of 0.25, I have about 40% power. If it's 0.3, my power goes up to a little over 60%. And then if it's 0.5, I'm up here in the 90% region. And if it's 0.67, I'm all the way up at almost 100% power. Okay. Now, in reality, it's very hard to hold all of these things fixed. You're going to want to consider various combinations of the scientifically important difference and maybe the variability and things like that to, I'll use Will's phrase, to stress test the design that you're developing. So I mentioned just a minute ago this notion of variability. So the larger the difference, the smaller the sample size is a reasonable rule of thumb, but it ignores the contribution of variability. What we mean by variability depends on what type of outcome you're talking about. We're sticking with the continuous example for right now. So in the continuous case, you need an estimate of the standard deviation or the variance of whatever endpoint it is that you've chosen. And so again, I've varied here the sample size along the x-axis, power along the y-axis, and I've changed only the standard deviation for a fixed effect size and a fixed alpha. And you can see in this case, I could have gone much further down because my power is very high. Even with 100 subjects, if my standard deviation is 0.75, I have 91% power. It's 0.67, 0.5. So you can see how it changes, okay? And again, you're not going to be able to use these graphs to figure out the sample size for any of your particular projects, but I'm just trying to give you a sense as to how they actually impact things so that you're informed when you have that conversation. So that's in the continuous case. It's pretty straightforward actually when you're talking about the variability. In the case of a binary outcome or a dichotomous outcome, what you're really talking about is what the control group's rate or response proportion is. And the reason that's important is because the binomial proportion is most variable when the proportion is in the middle, right? You can sort of envision that if P is for your binomial outcome, if the proportion is 0.5, what you're saying is you're not really sure. You could flip a coin and see what happens. So you're going to need more data around that to sort of pinpoint what's happening. And so in the situation of a binary outcome, again, this is our phase 2 clinical trial in subjects with acute ICH. But now we're saying we're not interested in the Neuro-QoL ICH trials, always use the modified Rankin scale score. And so we're going to stick with what everybody does, and we're looking to induce a change in functional independence, which is an MRS of 0 to 2. And in this case, actually, it is pretty standard that the minimum clinically important difference in stroke studies is often 10% on this binary outcome, an absolute improvement of 10 percentage points. And so you can see here, as the reference proportion or the control proportion changes, as it increases, the power for a given sample size goes down. So I can tell you without doing any calculations, because again, 10% absolute improvement in stroke studies is pretty typical. The worst case scenario for a stroke study is going to be a sample size of about 900 for this difference. And that is where we're talking about a reference proportion of 0.4, 0.5, 0.6 in that region. And you can see here that 900 gets us to about 80, 85% power. Okay. The reason I bring that up again is that that region is the worst case scenario. So if you're developing a clinical trial with a binary outcome and you say, I have no idea what it's going to be, again, that region will give you the worst case sample size. Okay, before I move on, do folks have questions about anything that we've covered so far? Because I'm gonna switch tacks for just a minute. Give you a minute to put something. I don't see anything in the chat. Okay, well, if you have any questions, again, please feel free. I'm trying to keep an eye on the chat box. Okay, so I mentioned to you that phase 2 clinical trials are hard. They're hard because they're often criticized as underpowered phase 3s. But of course, you can't design them with the same sample size that you would use for a phase 3, because then it becomes a phase 3. So what do you do about this notion that a phase 2 trial we think about as just looking for a signal, right? You just want a signal of efficacy. And so again, phase 2 trials are hard because often what we do is we say we're going to randomize patients, and if the effect we're going to go for an effect size that's twice what we would like to see in phase 3, just because it makes the sample size work out. And that's getting harder and harder to justify, at least to the funding institute that I work with most often. And so what has been discussed a lot, particularly in the stroke literature lately, is this concept of the futility design. And so I'm going to mention that to you just very briefly, because it is an alternative for the phase 2 space. So when you think about the superiority design, and again, I'm coming at this from the standpoint that what we typically do is an underpowered phase 3 clinical trial, and it doesn't give us all of the information that we want. It doesn't answer the question that we're really setting out to answer. So how can we fix it? So in the typical superiority space, our alternative hypothesis is that the difference between our control proportion and our treated proportion is different from 0, right? We don't care in which direction, and we know it's going to have to be a big difference in order to be statistically significant, because we have in our head that phase 2 trials are not allowed to be greater than a certain size. All right, so we would typically design this around a 2-sided hypothesis, using alpha level 0.05, because we think that's what has to be done. And in the example that I'm giving you, the control proportion was assumed to be 0.56. All right, so again, we're in that sort of worst case scenario range. Let's say the effect size that we want to detect with this alternative hypothesis is an absolute improvement of 12%. Okay, so the sample size, if I can afford 310 subjects, the sample size of 310 gives me only 59% power to detect this 12% effect size using this 2-sided alternative and alpha 0.05. Okay, you can say, well, what can I do about that? 12% is a perfectly meaningful effect size. In fact, it's probably bigger than what I would really like to see in phase 3. And so the futility design would flip this hypothesis around. And so instead of saying that you're designing a trial to detect a signal of efficacy, you would say you're designing a trial to eliminate the intervention if it doesn't have that signal. Okay, so the alternative hypothesis here, instead of saying, well, we're assuming that the difference between the treatments is just different from 0, I'm saying my alternative is that the difference between the treatments is less than a 12% improvement associated with the treatment. Okay, now because I've written it this way, that it's less than 0.12, it's automatically a one-sided hypothesis. I don't care if it's greater than 0.12, that would be awesome. So I gain a little bit with this one-sided hypothesis. The futility literature suggests that I don't need an alpha of 0.05. I can use an alpha of 0.1. And here's why. In the superiority case, if you make the mistake of saying that the intervention works, then people are going to use it. That's the assumption, right? And so there are implications to that this intervention might just be picked up and used because you found a significant difference, even in a phase 2 study. In futility, the implication of that type 1 error is very different. So if you make a type 1 error, that means you're eliminating an intervention that might actually work. So, I mean, that's bad for patient populations that don't have interventions, but in terms of exposing people to additional risk associated with the intervention, the consequence is not the same. Okay, and so we are willing to accept a little higher false positive rate here. I've kept the reference proportions the same so you can see the impact. Okay, and the effect size that you're detecting here is 0. So actually what you're saying is if the 2 interventions are exactly the same, I want to be able to detect this difference with 80% power or with whatever power. Okay, so the difference between what you're specifying here under the superiority alternative and here for the effect size is the same. We've just reversed them. Okay, but now in this futility case with a sample size of 310 subjects, the same sample size, you have 80% power to declare the intervention futile if it actually is the same as the control. So this can be a really big savings. And this actually sample size is associated, this assumes that you're still randomizing to 2 groups. If you don't need to do that, if you can use historical data or something along those lines, the sample size savings can be even greater. So just something to think about, that there are often, the futility design may be covered in another course. I'm not trying to steal anyone's thunder, but there may be alternative approaches that can help you keep the sample size at a reasonable level while still allowing you to answer the question the way you're intending to. Now, in many cases, we have closed form solutions. So for the t-test and the comparison of proportions that we just talked about, there's formulas for straightforward designs. But in many cases, we can also evaluate the operating characteristics under simulation. And so the notion here is that you're going to simulate or randomly generate the results of a given trial. And so in this case, the first row represents one simulated trial where under the conditions that we've talked about, I had a control proportion observed of 0.58, a treatment proportion observed of 0.606. My risk difference here is 0.025. The p-value is 0.644. Okay, so under that trial, I did not reject the null hypothesis. And so then I do it again, and I get now a risk difference of negative 0.03 and a p-value of 0.56. And you can keep doing this over and over and over again and keep track of what those differences are, what the p-value is. and whether or not that would have corresponded to a rejection. So in this case, just to show you the example under this superiority design that we just talked about on the previous slide, I went through this process 1,000 times. And the power is the percentage of the trials that reject the null hypothesis. So I only showed you 5 here. But over those 1,000 trials, 57% of my simulated trials rejected the null hypothesis. And that's compared with the 59% that we had from the closed form solution. Okay. You might expect that as the number of simulations that you do increases, that you might get closer, you might get a more precise estimate. Okay. So all of these things, before you have that initial conversation with your statistical collaborator, you should be prepared to talk about. Be prepared to talk about that level of significance. Don't just let them tell you we have to use 0.05. We always use 0.05. There are situations in which other things are appropriate. You might have a target power in mind. Often 80% is what we use, but some institutes might say, no, I really need to see 85%. Or that may be common in a particular disease area. So again, you need to be ready to talk about these things. The expected variability in the response based on the relevant clinical literature, if you have it. Even better would be a range of plausible values. So if there's been a number of studies recently in this patient population, having access to the full range of variability estimates, again, it allows you to stress test. Well, if I make the assumption that it's the best, the least variable of what's in the literature, and I'm wrong, and it turns out to be closer to the study that showed the most variation, what does that do to my power or my sample size? Be prepared to talk about the minimum scientifically important difference. What's the smallest difference that's going to change practice? And then if that sample size proves to make the trial not feasible, there can be some room for compromise. And I would argue to be open in terms of your experimental design, because there may, again, like the futility design versus the superiority design, there may be other approaches that will allow you to more efficiently answer your question. These considerations for the experimental design include things like, do you really need a parallel concurrent control group? I mentioned the use of a historical control. The term historical control has maybe not a great reputation, but it can be used in various ways. Can multiple questions be answered in the same design? Can you address things like selecting a dose and evaluating its futility? Can you do both of those things in the same design? Is a hypothesis test the best way to achieve your goal? Maybe it's not. If you're talking, there are selection designs which would allow you to select the best dose or the best intervention even without doing a hypothesis test. And so your sample size calculations then would want to focus on your method for selection and not the p-value from the hypothesis test. Is the design adaptive? And I'm going to give you an example of that in a minute, because there are some very common adaptations that are so common that we don't even really think about them anymore. Things like covariate adaptive randomization, things like interim analysis for efficacy or futility. Those are technically adaptations, but they're so commonplace we don't really think about them anymore. So in this case, I'm thinking more along the lines of response adaptive randomization, or selecting patient populations, things like that. The sample size calculation that you're going to use depends on the method of analysis, which depends on the design. So again, are you evaluating people at a single time point, or are you evaluating them longitudinally over time? If you are making use of longitudinal data, there are sample size implications for that. So you want to be aware of those things. And for some designs, simulation may be the only way to determine the sample size. So there's a question in the chat. Can you talk about when or why you would use a bootstrapped method like that versus a closed form estimation? So I am straddling the fence between using the closed form solution whenever it's available and using simulation. I know that there are many cases where both are possible. It is, in my opinion, sometimes easier, although we think about it from again, Will uses this term about stress testing the design. I can often stress test the design under lots of different effect sizes, under lots of different variation assessments faster using the closed form solution than I would be able to simulate the whole thing. That's not always the case. And there are some people who would prefer simulation in all cases because it allows them greater control. So to some extent, when both are possible, it's, in my opinion, it's just sort of a preference and how much time do you have and how much do you like to play with the simulations. But again, for many designs, the simulation is the only way to go. And those are becoming more common, I think, as we get better about acknowledging that the design should be appropriate to answer the question, and that that's not always a two-group parallel trial. So I'm going to show you an example. So this is an adaptive design that we have been working on, it feels like for a long time. So we actually had a planning grant to do from, yes, we had a planning grant a number of years ago to work on the simulations in support of this design. So I'm not showing you the final design, which was more complicated, but I'll show you what we went into the planning grant with. So in this design, we are taking eligible subjects and we are randomly assigning them to 5 dose groups, a placebo group and 4 doses of the intervention. And the primary outcome here is RV function. The notion is that we have this primary outcome quickly available after 24 hours. And so after a brief burn-in period where subjects are equally randomized to the interventions, that we would adaptively allocate patients to the interventions that look like they're doing the best. So it's effectively increasing enrollment in the good doses, decreasing enrollment in the doses that don't seem to be working, and hopefully avoiding too many enrollments in the doses that are too high and go, above where we would be afraid of safety concerns. So when we went into the planning grant, we did a very simple simulation study that looked at, in this figure 2 that you see up here, it's kind of small. The null hypothesis is that there's no effect associated with dose. And our primary outcome at that time was actually a binary indicator for whether RV function had normalized. And so we have this null that says 5% of folks are going to be normal at 24 hours versus this alternative hypothesis where we think that the normalization proportion would increase until the second to last dose at 75, and then would sort of start to plateau at that point. And so what we did then is we had to simulate what would happen under these various scenarios. So on the top right, you see the operating characteristics under the null. So we simulated patients assuming that everybody had a normalization proportion of 5%. And under certain stopping characteristics, or in our case, we were looking at the probability that there was at least a 10% benefit. And we wanted that probability to be high. We wanted it to be 0.85. So this was actually a Bayesian approach. And you can see here that regardless of the sample size, we were very unlikely to move one of these interventions forward, although the design always picked a dose. And you can see that the dose most likely to be picked was the lowest dose, which is good, right? If they're not doing anything, you want to pick the lowest dose as your best. So that was the most likely to be picked, but it was very unlikely to show that it worked well enough to move it forward. Down here, we show the performance under the alternative. And so again, what you can see here, the diamond is dose 3 and the X is dose 4. And you can see that they're about equally likely to be selected. And again, these are these 2 doses. So because of that plateauing effect, it's a little hard to distinguish whether this one is the one we should pick or this one is the one we should pick. So it's picking them roughly equally. But you can see that the sample size, as the sample size increases, the likelihood that we are able to show that 10% benefit increases as well. But we hit this plateau, right? So we're at 80%, maybe starting right about here. And then we get some improvements, but not a whole lot, right? Not enough to make us think we need sample sizes out in this range. And so then what had to happen during the simulation that we actually did under the planning grant was, again, to do the stress testing. So we picked, let's see, 3 other forms of the dose response curve, each with 2 different effect sizes and 2 different assumptions for the variability. And so we're looking at, under all of those scenarios, what do our operating characteristics look like? What do we want our stopping boundary to be, and things like that. So again, in some cases like that, there's nothing to do but to simulate and see what happens. So when we justify the sample size, it's important to think about how many subjects, is it adequate, and be honest about this. Do you really need more, or could you answer questions with fewer? And if the answer to either of those is yes, explain why. You can calculate the sample size or the detectable difference. We often have to do it both ways, because again, there's sometimes back and forth between the clinically important difference. There's lots of freeware available on the web, and your statistical collaborators will have lots of options available to them. And I'll just leave you with this quote from Dr. Lentz at the University of Iowa. You all can read that while I ask if there are any other questions that I can answer.
Dr. Yeatts, thank you for a great presentation. And I think this is just what is needed at this stage in the course. I think building upon your question about that you were addressing about when you might want to use simulation versus closed form solutions. I think when you're really starting out, to make sure you're in the right ballpark, where many of you are in the course, you probably don't want to make things too complex. However, there may be things where, if you are using a design where there's some relationship of the information from inside the trial to what the trial is doing, like an adaptive design, a lot of things can affect that. One of them is really the accrual, like how quickly patients come in, because your trial's ability to make changes to sort of gain efficiency. If you're studying something like aspirin and it's 20-year reduction in mortality, it's going to take a really long time for you to have any information, and that is just something to consider in terms of those situations, like that sometimes it can be helpful to do it that way. And the other reason it may sometimes be helpful to run simulations is it gives you this little sense as to like all the little bits and pieces that are going into the design. If you're following people over time, predicting when they will have events, if they're going to have events, and all those sorts of things. So it makes you think about a lot of the nuts and bolts that if you're just kind of using a stock equation, you might forget about. And then one of the mistakes that I think we as clinicians do is sometimes there's a lot of nice calculators out there. Power and Sample Size has a nice website that will output our code. But sometimes we don't read the fine print, which is like sample size per group. And then we come up with we're 100% off on our sample size error, which I've done.
Yeah, those are good points. So I answer the questions to why I would do simulation versus something else, but depending on the phase of your study and how the other thing I think I would just stress is that although I think Will's point is well taken, you have to realize that the simulation piece, if that's what's needed or even what's desired, may take longer. So if you are concerned about when should I talk to my statistical colleague about starting this process, sooner is better, especially if you think that simulation is going to be involved, because it sometimes, to do my silly little binomial example, Will and I've touched base by email and I wrote it in a couple of minutes. The hat trick design that I gave you the example for at the end took significantly longer. So you do want to keep that time in mind. There's another question. If you fundamentally don't have a precise about the variance in your outcome measure, does this demand pilot data before even thinking about sample size? So you can, in theory, you can do a sample size calculation for a continuous outcome using a standardized effect size. But as a reviewer, whenever I see that, I want to see it translated back under certain conditions. So even if you don't have a really precise idea of what the variance is, if you have a range, then you can translate that back. I think that's helpful. Often what I see are folks who say, I have 80% power with 20 subjects for an effect size of 1.2. And I know that's on a standardized scale because that's the only thing it could possibly be with such a small sample size. And I have no idea what that means in terms of the outcome scale that's proposed. So, a pilot study might be helpful, but again, you have to be careful how you design the pilot study. Are you designing it to estimate the variance, or are you estimating the variance from what you're proposing as an underpowered phase 3 study?
Where are some good places if maybe in your exact study population, you might not have a great understanding of the variance in the continuous outcome measure? Where are good places to potentially look in the literature to help kind of guide what sort of boundaries on them there might be if you don't really have a good sense?
Are you asking me?
I guess what sort of sources of information would you like a clinician to find and bring to you?
Yeah, so if you have, if there are previous studies in this patient population, helpful would be in a similar intervention. Sometimes one thing can transfer to another, but I wouldn't be able to know if what you're bringing is applicable. So I think it's helpful if you know what's been done in your particular disease area. Sometimes there are meta-analyses or systematic reviews that might have all of this information sort of compiled for you. But definitely, over the last however many years, if you're an up-to-speed consumer of the research that's being done in your area, as a clinician, you're certainly going to have better access to what those estimates might be than I would.
Well, I think at this point in time, we've reached the end of time. Lisa, did you want to post the evaluation link? Because anybody who didn't arrive exactly on time, it may not still be showing up in chat. If we could put that evaluation link back there, and join me in thanking Dr. Yeatts for spending some time with us. And I very much suspect that after this 1-year vacation from the CTMC. We will probably be seeing you again soon on our core faculty list.
Sounds good. All right, you guys have a good day. If there's anything else I can do for you, let me know.
Thank you.
Bye, guys.